Hello and welcome. On behalf of Interior Health, we would like to recognize and acknowledge the traditional territory of the Silk Nation, where we live, learn, collaborate, and work together. The IH Research Week 2018. Today's presentation is Patient Engagement and Research, and will be a panel presentation with Karin, Maiwald, Burgener, Airth, and Kathy Rush. Thank you all for joining us today. Take it away, Karin.
Thanks, Kim. Opportunities today about patient engagement and research. There's a couple of people that will be presenting today. Very welcome to present today. Can you give me an idea about how many people are in the room?
Okay.
Oh, good, thank you. So this is just today an opportunity, very brief introduction to the strategy for patient-oriented research, but as well patient engagement, the work we have been doing in interior health. My name is Karin Maiwald. I completed my PhD some time ago, and I'm a happy staff member of Interior Health Research Department. And I'll be talking to you for the next slide. Kim? A little bit, very briefly, and the resources are the last slide. I'll say a little bit about the strategy for patient-oriented research. This was an initiative that started via the Canadian Institute of Health Research. The SPORE program, the SPORE initiative, was started in different provinces in this country. The last province to come on board was British Columbia, and the formation of the BC support unit was about 2015 to 2016, and it's hosted in Vancouver, and we call it the Vancouver Centre or the Hub. As a part of the BC support unit, we have 4 regional centres. Each regional health authority is integrating or implementing the BC support initiative in the various health authorities. This is a partnership between the BC support unit and different health authorities. So what we have is a Fraser Centre, Interior Centre, Northern Centre, and Island. Interior Centre is expected to bring the opportunity for collaboration in research and research process, research-related activities, as well as offer services and support and deliver training. Also increase the availability and the utility of data and related services to that for patient-oriented research. What is novel is in the Interior Centre is that we started with a patient engagement and research committee. This committee was formed in September 2016 and started with the thought of perhaps having 3 or 4 patient partners work with us to assist in the development and implementation of patient engagement infrastructure. However, the response was very positive and somewhat overwhelming, but very exciting as well, because we had way more people respond to the call to the recruitment advertisement. So we actually started with a somewhat bigger 85 people, which was then identified by the committee itself that they would hope to go up to 7-8 patient partners. Next slide. Who's on this PEiR committee, as we call it? We have Paul Burgener, who will be presenting just after me, and who is from Nelson, and I happen to be as well based in Nelson. Marilyn Parker, who is now in Kelowna, but has been living in Kamloops for some before that. Tim Charlie Boy joined Williams Lake. Alison Coleman, Fernan, Sheldon Dyer, who lives and works in Cranbrook and lives in Kimberley. Darren Gregory, and I apologize, Darren, is just well, it's near Creston, and Michelle Hewitt from Kona. Former patient partners are listed below, but what you can see is that this committee is formed from different people from the interior region. They were all recruited through Patient Voice Network. However, the committee is open to membership of people who prefer not to be part of Patient Voice Network. Myself, I'm the co-chair of this committee, and our team is strengthened by Nellie Opie, who is the academic co-lead of BC Support Unit Interior Centre. Next slide. briefly and very quickly, a tiny bit of an overview of what we've been up to since 2016. So one of the main activities in the first year of the work that we have been doing together is to develop, for example, a patient engagement and research plan. Part of that was to develop the terms of reference for this committee. This committee has as well contributed to research policies development, as well as provided input in the research refresh, which is the strategic plan update, which will be presented tomorrow by Dr. Yvonne Lefebvre and MD Taylor at 11 o'clock. As well, the PEiR has been presenting at research department events, for example, the launch of the BC Support Unit Interior Centre, the Royal Hospital research launch together with Thompson University, presented at guest lectures, for example, nursing students and social work students, UBCO, Thompson River University, Selkirk College of the Rockies. Hopefully in the future we can also present at other colleges in the interior region. We've also presented as a PEiR committee at provincial events, for example, the BC Support Unit Provincial Conference, which was held last year, October, and is coming up again in October of this year. Some of the PEiR members are involved in provincial research projects, not only in British Columbia, for example, the BC Connections Project, but as well, for example, TRAC, which is a large cross-Canadian, pan-Canadian study. So what we're doing more at present is we're still involved in these activities that I just mentioned, but as well participated in workshops that were delivered through Interior Health. What we're more focusing on right now is to engage the PEiR committees themselves so they can experience as well this collaborative approach in research and full patient engagement to be part of patient engagement research projects. For example, we will be doing a study which is named the Environmental Scan for Patient Engagement Initiatives in Interior Health. Also, they will partake in the design and development of training and workshop, which is more focused on patient engagement and patient-oriented research, to be delivered starting this fall. As well, the PEiR committee is involved in mentorship, for example, students, but as well researchers and healthcare decision makers and professionals who want to involve patient engagement elements in the research that they are doing. In the future, what we foresee is to continue the activities as we're doing them right now, and also is really planned to demonstrate true patient-oriented PEiR research project. And one of the concerns that we try to address and want to address is to better implement findings of these collaborative projects. Next slide. So very briefly, what is patient-oriented research? Research that is conducted in partnerships with and by researchers, patients, healthcare professionals, health decision makers. It is important to parse these questions and measure the outcomes that matter to patients. Because the research is to aim to improve the healthcare system and practices. Next slide, please. Very brief overview, and much of this will be discussed during workshops and training coming up, so I welcome you to take note and express your interest if you're interested. How is patient-oriented research demonstrated? These are just some definitions. Criteria are coming from the Canadian Institute of Health Research. Engage patients as partners. It is focused, as I mentioned, on patient-identified priorities. It is to improve patient outcomes that are important to them. And it's really important to consider, are you measuring these outcomes that matter to patients throughout the entire research cycle? Also, multidisciplinary teams in partnerships with relevant stakeholders, and it aims to apply the knowledge generated or that we're mobilizing to improve healthcare system and practices. Next slide, please. The simple picture is to identify only briefly, and it still is linear, but I want to show the interactive mechanisms that take place between patients and researchers and healthcare providers, professionals, and health decision making, where this empty space that you see in the middle, patient research partner, is not an empty space per se, but really is about the interaction interaction between the different parties where we are setting priorities together, where we develop the research agenda together, etc., research design, conduct research, and in the end, disseminate, implement, and evaluate as well. So this is only to show very briefly the dynamics that are very interesting, also complex for the different parties to navigate through. Next slide, please. So I just want to mention this slide again from the PEiR, what we mean by meaningful and active collaboration. We talk about that in terms of governance, priority setting, and conducting research, and knowledge translation. Now, I just create this little bit. There's much focus when you see the drawing. There's much focus, if I am conducting research, and there's more attention given, for example, knowledge translation. But this whole piece of governance and priority setting is considered important. We want to talk about meaningful and active collaboration in research process. So a thought on that is that the objectification of spirits happens. So we are starting to measure it, and so that we're really speaking to the cognitive sense. We're starting to measure it. We're talking about GRIP2 from the United Kingdom as an evaluation measurement tool, the PEiR, which is coming from McMaster University. However, I would encourage everyone to encompass the feeling and the sensory and the aesthetics in shared efforts in research over time, and I will speak to it. I would love to speak more about that in the future. Next slide, please. So in conclusion, what I can say, realizing I'm taking up a little bit more time and research, found is that patients in past and present, there's still a place that patients have to follow research plans, yet perceive little influence, cooperation, and loyalty. They find research is not implemented. Patient involvement in health research is not a new idea, but investments, requirements, and incentives for doing this are new by patient, the strategy for patient-oriented research. I wanted to bring forth that patients in the Lower Mainland agree on the intention of the provincial patient engagement strategy, but elected strategies that we expected to implement in the interior region do not necessarily meet the needs of people in the interior region. So the thing we have in front of us is how is this new way of involving patients actually working within quality improvement and research practices? This is still unclear. And I'm very excited to share that IH agreed to doing in-depth and detailed study to answer that question, which we named Environmental Scan Patient Engagement Initiative Study. In order to improve patient engagement in research practice, the researchers, healthcare professionals, and decision makers have to adopt reflective practice and choices, next steps they make in the research process. Next, please. This is my last slide. It's just a very quick overview of some resources, and there's also contact information. Thank you very much for your time.
Thanks, Karin. That was a very full presentation. We appreciate it. Are there any questions in the room or online? I know we have lots of people joining us online as well.
If we could do questions in the end, that'd be great.
Okay, fantastic. No problem. I'll just pause presentation up and running.
Nope.
Apologies. There's a few.
Fine.
Great. Okay. So, you need a battery?
Yes, please. Well, I'm Paul Burgener. Background, I'm not in the healthcare side of things. I've come out of industrial research and commercialization of things. I'm a professional engineer, sort of engineering physics in a strange way, and a certified management consultant these days on commercializing technologies. I'm recruited by the Patient Voices Network to be, one of the voices that they could stick on focus groups from periodically, and a very easy approach to life. And it has grown to spending a lot more time rather than just being occasional phone call. But yeah, asked by Karin to do, and I've been working with Karin now for almost 2 years, is some of the view that I've seen as sort of the patient voice, again, as not as strictly being operated on in a research project or as a patient in the hospital, but voice. And so it's a broad aspect of what happens in the community. As a patient, we're all patients from time to time in the medical sense. We also have our views as to how things should work. That a patient voice improves our research effectiveness. Again, my commercial side of things, I did background, just provide different views. People ask different questions. We have our own personal networks that sort of 6 people away from somewhere. If anybody participates in LinkedIn, you can see the connections that end up with very few people that you know, and then they know somebody else. So from the research side of that, one may have the background of the researcher, and typically you don't, but you do have connections that you hear about, and it just has more eyes and thoughts on what the researcher is actually trying to seek out and connect with. So with patients, is expanding our healthcare in the sense that we're doing at the moment. We're using a communication technology that, again, is not new. I often complain it's actually a rather ancient one using WebEx, but it's but as we move out into the interior side that I'm familiar with, we run into things that WebEx is working very nicely to me in Kelowna today. May not be working very nicely in Williams Lake. Our bandwidth is not the same. The power supplies change up and down. The computer literacy, if you want, at times by people that are separated from a center, they have to do everything, which means there's something that is always a little access to how to understand things and the time to get it together. We're going to look at patients that are scattered about in our mostly empty province. Have to learn better communication technologies. And in the healthcare, this also deals with some of the dealing with patients at distance. So it's a problem. And so just having patient voices that are being brought in to talk, we have to have better communication technologies, and that will also enhance our abilities to deliver healthcare too. And under how would I class it? Underutilized aspect of the patient voices when one is looking at doing research is to put in volunteer hours. So from the budget side of things, you are not necessarily having to find more dollars to have somebody provide some assistance to look at something, have to gather some information. We have seen on some of the committees I'm involved with, different researchers saying, I would like a group of people to review the following things. I've got these questions to help formulate either their proposal or actually their actual work that they're dealing with. And through Voices Networks and the various other committees that are coming out of SPORE, we're able to tap into this sort of expertise. So it leaves some of the time constraints on the researchers to do what they are really excellent at, and by some of the more mundane or simpler aspects in a non-financial consequence to the researcher. And I think that is something that is starting to be seen, but I've certainly seen it from the interactions that I've been involved with. Next slide, please. Patients bringing new resources. as a, again, not one being researched upon, but as a voice, we're into the research system. So we ask different questions, such as, gee, this seems really nice. Why can't we run a small trial? And of course, everybody realizes there's ethics and there's protocols and there's scientific procedures and all the rest of it, and the overriding one is we don't want to hurt anybody. But asking some of those questions in an uneducated way as to what the system is doing does the system that, well, maybe there is this or that we able to do, and it can change our approach to things. You know, example being my background in industrial cost accounting. That a lot of providing healthcare problems, which especially in the interior, is because of distance. It's a problem, not a healthcare problem. We have lots of healthcare people that provide all sorts of services, but provided to a community that has 400 people. And we find it by saying, well, get on a bus, which of course is being canceled in October, or hitchhike, or find a friend, or drive your vehicle. And you say, I'm not really feeling well. And you say, well, that's too bad. We have a central facility. It's only 4.5 hours away from you. And of course, pay for it yourself. And as again, there's mechanisms to get money back if you follow the paperwork in advance. But up at the hospital on your own accord, it's your own expense. So those are sort of things that Karin has mentioned, that things that work in a major center don't necessarily work when we get into the more scattered, smaller communities across the interior. Looking at it as a healthcare problem means that, you know, how do we find people, how do we get this, as opposed to looking at it as a budget point of view of, well, problem at all, and providing service to Williams. We just put a specialist on an airplane and he's there in 2 hours and he looks after it. That is a healthcare problem. That's really a budget problem. And I realize there's a limit of dollars, but it doesn't mean we can ask questions differently. And in that we are asking that, how do we deal with remote interactions through some of the digital technologies? Assuming you have a good width that you can interact with people, but they'll be solved, and we can ask different questions. Again, patients are involved in a lot of different forums and committees. If, as I found out myself, that I'm now presently on patient-centered committee practices and some other research side of things. I'm dealing with things that are simplistic from a research point of view, but I hear things. And you know, I notice on the topics of today, there's somebody going to be talking about wound healing. So if you see that, I do know some people that are having problems with wounds. I reflect that back to somebody who has the technical capabilities to do something about that. So we bring a broader awareness just because we're involved in more things, but perhaps a wider breadth of it that we're able to bring back to the researcher and say, well, have you run across this or that? Whether it's meaningful, that's the researcher's expertise. And do this because I've seen that patients bring results in projects. One gain typically, but I have certainly seen that from an administrative point of view, interior health and the board type of programs, there's very good feedback to the patients as we've been involved in different things, that there's a commitment that we have a report back as to what difference made or how it was received, and then faithfully followed along. Simple things, was in a new pilot sort of program on mental health and addiction. And it can pass us as a group of people, what do you think about this? Isn't it nice and all the rest of it? And it was put out, well, unfortunately, and it's fortunately, mental health has got stigmas when you are in the general public. of, well, crazy, and that is totally wrong, but it's a public perception. And so the name got changed to a wellness center. So what does it mean? Well, then you have a chance to have a dialogue and discuss what it means, instead of somebody looking at it as a generic name with a potential stigma because of lack of information. As part of that center, they got some nice posters to say, this new center is there. It looked like somebody went on the internet and clipped something out of a U.S. set of pictures, because it tended to have, an Afro-American and a Hispanic and a very white sort of person and all the rest of it, for a community which has a very strong Indigenous community and did not reflect at all the view walked around in Kamloops. And so they looked at that and said, do you think it matters? We said, well, yes, you're trying to go and talk about a new way of introducing things to a community, and you've got people that don't belong in that community at all from the pictures. So they approached different agencies that were there that they worked with, and they had volunteers come forward and say, you can use my image and I will talk to what you're trying to do here, because I appreciate what's happening in the community. So it made it local and personalized, as opposed to, well, here's something that doesn't really matter to us. We proposals, there are things that have come through, certainly the patient engagement and research, where different researchers had provided, they were trying to get some funding with, side of stuff. We were saying, yes, it's a patient focus, and at the end of the project it said, and we will be interacting with patients. Well, that didn't really seem patient-centric. And we poked at that, and unfortunately, as part of our peer review, that we did realize some of the academic requirements that also went along with making the research, and I think adding in a very strong proposal for interaction with patients and how it would benefit, again, in the interior context. We bid on some of the academic requirements, so as a committee, and that will be shared then into the future. We not make that mistake, and will be more balanced in is provided back to researchers looking at how they meet this criteria and still get their academic requirements also fulfilled. We had been asked on an interior health reach survey about various things, and we came back and said, well, you've forgotten the following aspect. And that added in, and it ended up on their annual report of saying, originally we looked at 3 aspects, we added a 4th one. And again, there was positive feedback. If you looked at Karin's slides, there was only 2 specified, PEiR and PEiR, which I suspect health-wise is evident as patients engaged in research and patient-oriented research. But there's strong patient pushback. If you want to deal with patients, talk English, don't talk some special jargon. There's a whole book put out of different wording as to, yes, it looks like this word, but it means something else to the healthcare people. I think this is a general problem with any specialized group. It doesn't have to apply to healthcare; it can apply to anybody else. So, and various other things that we can look at. We've used. I think what we're saying here is there is a lot of different cases that even in last year we've seen involvement with patients, and they've seen results coming back, and that's made it worthwhile going forward, that we're able to talk and be valued. It provides a context, and it just improves our overall health care. Next slide. There we are. It's important to have patients involved, both for the patient and the researchers. we get to share experience. Research in human beings is a full context, mental side of things and placebo effects and all the rest do affect your results. So it's not just a pure scientific structure. There's this human context, and we need to be involved with the people in that context. And a lot of research funding, I think, is driven by public advocation. If the public really wants it, it's publicly bad to go against your will, the people that vote you into the service. So the more the public understands research is really needed, the more education we get in moving it forward. And we've seen the healthcare administration values the feedback and continues to stay in touch. So thank you much. Last slide is contact side of things. Karin is the principal person, but if someone wants to bounce something off me, I'm available to. Much.
Thank you, Paul. We'll get more. Sorry, I don't have my glasses. So, welcome everyone. Thank you for taking the time to be here or tune in online today. My name is Leonard, and I'm a Master of Science in Nursing student at UBCO, as well as an RN specialized in mental health. So I'd like to share a bit about my research for my thesis and how, as a research team, we've taken a patient-oriented approach. So my thesis is on the experiences of rural older adults with mental health concerns, specifically in Princeton. I'm realizing now I sent the copy of slides. It doesn't have the link for where this picture came from. So I did not take this picture. I'll send that for the recording. But I chose to start the presentation with this picture because it is a bridge in Princeton, and to me it represents the gap that we're trying to bridge between care providers' assumptions and patients' experiences in research. Next slide. So it's myself. We have a research team consisting of Nellie Olkey with the School of Nursing at UBCO and Carolyn Sostek with the Department of Psychology at UBCO. We have Karin Fulton, who's a registered nurse specialized in mental health in Princeton. Aaron Evans, who's the president of the South Okanagan and Similkameen Mental Wellness Society. And Nola Mensch, who is our patient population representative and an integral part of the work that we're doing in Princeton right now. We've also received from the CNS, the SOS Research Foundation, UBC, and MyTAC. So the study aims to understand participants' experiences, to empower the participants, and to provide evidence for practice decisions in rural areas with older adults who have mental health concerns. Using critical social theory has meant focusing on inherent power imbalances, which NOLA has helped us identify, related to those with and without mental illness in Princeton. This will also mean taking action on our findings. Entire description defines reality as complex and subjective, and in the case of this study, we are aiming to address the gap in care for the population in rural areas.
Please make sure to mute your line. We're getting some background noise on the video.
So we've chosen Photo Voice as our data collection method, which I'll elaborate on in our next slide here. And finally, we are using constant comparison to analyze the data.
We're still getting that background noise to whoever's on the line. Please make sure to mute your line. You can press start.
Photo Voice was developed by Wang and Burris in 1997 to empower women who were living in rural China. And we chose this data collection method to ensure that participants could clearly articulate their experiences through photos, interviews, and captions that they provide. We discussed this decision with the research team, and NOLA particularly agreed it would be a beneficial way for people to share their stories. And again, it aligns with our philosophical opinions and the methodology as well. Next slide, please. The Photo Voice process encompasses a number of steps. Initially, we held an educational session on the ethics of photography, examples of how to document mental health experiences, and how the cameras provided. In addition, we gave time for participants to ask questions and offer feedback on how things were going to look over the next couple of weeks. After 2 weeks of participants taking photos, I held individual interviews and reviewed photos that participants selected as the most significant and used the node method to elicit responses which would target our objectives. Again, method of interviewing was discussed with our population representatives. Matching will occur once all participants have been interviewed and we have themes to share with the group. Science will be discussed with the participants to see if this is an accurate reflection of their experience and not just the assumptions of us as researchers. Knowledge translation will occur in partnership with participants. They will determine how they would like to share the findings with their community, which could be a gallery night, photo books placed through a community, or the use of a website. We also explain that since this is part of my thesis, findings will be published in relation to my studies. You can see we've taken a few steps to ensure the participant population is in control and part of the process and the findings that will be shared as part of this study. NOLA was approached and agreed to take on the role as patient partner on the research team, as she has participated in previous research studies and is involved in advocacy work around Princeton regarding mental health. She's a team member on the research team, which includes researchers and care providers, as you heard. She was able to speak to the culture in Princeton around mental health, including how to recruit, how people would become, or where people would be comfortable meeting, how she thought meetings could be conducted in a way which would make the participants comfortable, and gave input on each step of the research process as it was discussed prior to data collection. So the research stayed true to its design, addressing critical social theory by ensuring not only the data speaks to the participant experience, but that methods align with what is needed in the community and what participants would feel comfortable engaging with. Additionally, this means we're using an integrated KT approach by having a participant with lived experience as part of our team. Her contributions have been invaluable to our project so far. Participants have also provided informed consent throughout the research process for sharing their photos, being recorded, how they wish to be acknowledged for their contributions, and which photos they're comfortable using. Checking occurs, the participants will also have part of the final say in what our true findings are. So far, our participants have opened up about areas of their life they haven't shared with many people, feel are an important part of their life as someone with a mental health concern in Princeton. Recruitment has occurred in partnership with Karin, Sharon Evans, and a member of the Princeton Mental Health Clubhouse. As predicted by NOLA, we've had some difficulty recruiting people as they're afraid of being associated with having a mental health concern in a small community. We were able to talk to NOLA about what recruitment process she felt was best to work through that. And some themes from interviews have been identified so far. These are very preliminary, as we've only gone through about 4 interviews so far, and Carolyn and Nellie will also be reading over the transcript. Additionally, the research team members, including NOLA, will be involved in discussions around our themes that are identified. Next slide. So, they're taking the time to hear about this research and the importance of having patient population representatives involved throughout the research process. I know for us it has been invaluable having NOLA as part of our decision-making process out, and I'm really looking forward to member checking and knowledge translation activities that we have coming up.
Okay. Well, if you can unmute your line, I'll get your presentation up. Okay.
Great. Can you hear me?
Gotcha.
Great. Good.
All right.
Thank you for.
Sorry. Go for it, Kathy.
Great. So thank you for the opportunity to be able to share a little bit about how we have engaged a representative in our research. And I'm just going to go to the next slide. So I just want to give you a little bit of context for patient engagement. And so this particular funded project relates to urinary incontinence. And as you would be aware, most likely it affects a significant proportion of our population. So 3.5 million Canadians are affected by urinary incontinence, and certainly the highest prevalence is in older adult men and women. And so older adults often suffer in silence with urinary incontinence, and about 50% really never seek help for their symptoms. So left undetected and untreated, it is a condition that certainly can probably get worse, and it makes management that much more difficult. And so early detection and referral are really critical. So we and looking at ways that we might be able to address this particular situation. So we came up with the idea of self-screening as one approach that could perhaps facilitate older adults in terms of health seeking related to this particular health issue. And so using a randomized controlled trial, we're comparing a self-screening process to usual care to determine whether the intervention impacts health seeking, quality of life, and then just symptom management. So the next slide introduces our team. I haven't sort of given specific names to the team members, but we do have clinical nurse specialists in gerontology, an epidemiologist, a geriatrician who specializes in urinary incontinence. We've got some trainees, and we have a patient with urinary incontinence. Our patient engagement. So with this particular health challenge, we thought it was really very important to have someone with urinary incontinence just to help us navigate some of the issues we anticipated around, and these have been mentioned in previous presentations around recruitment, just some data collection, and just even knowledge translation. So we certainly wanted to involve a team member, a patient representative. We also, as has been mentioned, want to maximize the usefulness and relevancy of this research and the outcomes for our user group, and then to promote the success of the project. It was important also just from knowledge translation and uptake perspective to involve someone, and it also a requirement of the funder. And the specific wording in the call for proposals was the project needs to be developed with and for older adults. Next, patient representative. So our patient representative with someone who has urinary incontinence is a female who is a young older adult in her late 60s, is married, is active. So you can see here that she engages in lots of different activities, from taking language classes to whitewater rafting. She's very well educated. She is a retired teacher with a master's in education as her highest degree, and she's highly motivated. So she calls herself a lifelong learner. And so I put this up here mainly because, of course, one of the challenges is inviting a patient representative who really represents the patient population. And we are very aware that our patient representative, who has been invaluable to the team, does not entirely represent the population of those with urinary incontinence. And for example, we don't have a man on our team at the moment, but certainly this problem is an issue for men as well. And certainly having, another patient representative to represent that side of things would be beneficial as well. So we are aware that we are bringing a certain voice to the table. That was mentioned in Paul's presentation. Next slide, please. How have we engaged our patient representative? So our patient has been involved in all activities related to the project and certainly has volunteered far more than we anticipated. She has been very enthusiastic and we have really appreciated her contributions. And so she has been really involved since the inception of the project. So with the idea, she liked the idea to be able to do some self-screening and to look at impacts on especially help seeking. So she was involved certainly even in submitting a CV. So the funder required that all the team members needed to put together like a 2-page CV for purposes of the submission. And so she quickly put hers together, updated it, and it was submitted as part of the package. And she certainly was part of even like reviewing the materials. She perhaps didn't review them as extensively as the rest of the team did, but she was certainly a part of being able to feedback on certainly the ideas and just what we were doing. She has been involved in the ethics piece of it as well. She was very keen to be able to complete the TCPS2. And so, for all of you or any of you who have done those, they are time consuming. She was so enthusiastic to complete them. She probably had them done before other team members who also had to complete them as a requirement for ethics approval. So she is a named team member on our ethics certificate. She has been certainly actively involved in just reviewing recruitment materials as well, particularly with the sensitive nature of urinary incontinence. It was really important to have someone who could take a look at the language that we were using and to ensuring we were using language that would encourage people to participate and to feel more comfortable or to the extent possible comfortable in participating in the project. And so that was extremely valuable. Someone else looking at it might have some different input, but certainly our patient rep has been really helpful. Also, in terms of just recruitment venues, has been really helpful in identifying ones that we would not have necessarily thought about. And again, Paul certainly alluded to that, and just in terms of the networks and the connections that our reps have. They can certainly the lines out there in ways that we can't necessarily do so. She's also been really helpful in terms of even identifying incentives. So, for example, typically we might go with coffee gift certificates to give to participants for the patient, and wanting to sort of know whether that would be appropriate for this particular population. And indeed, she sort of has redirected us in terms of the more appropriate kinds of incentives that we would want to use. We also will be doing, we haven't gotten to this stage, we are still in the process of recruiting, and we continue to have challenges with that, just like Lauren was alluding to in hers as well. And so we continue to recruit, but we will be, and we have been doing some KT, so we've been doing lots of going out into the community to talk about the project, and getting feedback even that way in terms of learnings to assist us. But she will be certainly involved in the Cafe Scientifique that eventually will hold, and other KT activities as well. Slide, please. Really end with just some reflections on having a patient rep on the team. So certainly there have been benefits to the team and benefits to her, I think. So certainly we regard her as a full-fledged team member. She really is one of us, and she makes contributions that are different but complementary, and equally as valuable as other team members. And I wanted to pick up on something that Paul mentioned, just in terms of she has not been really intimidated with the whole research process. And in fact, I think perhaps some of her background, having completed a master's and so on, she has been relatively comfortable with kind of that whole research process, and has asked questions, I think, that have been very helpful to us. So it's been one I would perceive that hasn't had a whole lot of power differentials. At least I would perceive it in that regard, that we are certainly equal team members in this whole venture. And as has been alluded to, offered sort of that insider experiential perspective that we cannot bring to the table. And again, contributing networks that have been valuable for recruitment and will be for KT efforts as well. And then just benefits to our patient. Certainly learning new things has been important to her. She regards herself as a lifelong learner, and a comment she made was, "I think my brain just woke up just from a few years of inactivity." So she's been really excited to be able to be engaged in this way, contributing to a project with potential to make a difference in lives of people with urinary incontinence, and just feeling valued for the expertise and insight that she brings. Are just acknowledgements to our team, to the folks who are supporting, so the University of British Columbia, Interior Health, and to our funder, the Retired Teachers of Ontario.
Happy.
Thank you.
Any questions for any of the presenters, either on the line or in the room?
I'll pose a question. I just my voice will carry over the mic here in Patient. I'm with the Interior Health Research Department. So thank you to all four of the presenters. Wonderful presentations, and they certainly gave us a very good mix of views on how patients can truly engage in research and be part of research teams. And I think we can all certainly appreciate and anticipate the benefits and payoffs that health research will have the more and more that we engage and involve patient partners in the process. Apart from the two researchers, and I think Karin and Paul would certainly agree with me, one of the challenges in health research that involves human participants is always recruitment. It seems to, it doesn't really seem to matter often what the topic of the actual research project is. We do a lot of facilitation in our research department, and often recruitment is the key piece where a research project, despite all of the good intentions and hard work and funding behind it, will often get stalled or delayed or kind of fall short. And I was listening to the 4 presentations. I think this is an area where maybe patient partners can really, really help us. And I think they probably have a lot of potential in helping us to recruit in ways that we probably haven't even anticipated as researchers before. Like, often we're really not still connecting with the people that we really want to do the research with. And I just wanted, there was a few reflections from the presenters on how can we have patient partners help us with that recruitment process. And there are other potential and maybe other avenues for recruitment that they might bring to light that we just traditionally haven't used.
We did the healthcare portals in Nelson. Starting then, I was a patient voice and have been on just some things, and I happened to be on that one. And there was they centered to sign up out of the hospital because from a budget point of view, you don't have to pay anything. To down Vancouver or even here in that was quite an easy, accessible situation. The hospital was a unique place for Nelson. The hospital Nelson happens to be from downtown. There's about 100 steps vertically to get to the hospital downtown, or you can take the bus, which takes about an hour from wherever you are. And then you did your 5-minute sign-up and then had to wait for a bus to come in. So you end up with about 2.5 hours to do 5 minutes. The treatment nurse was assigned with the task of signing people up, so you had to do her obvious care side of things as well as stand there and add more duties to her. They sent somebody out to sign people up who was there between sort of 9 and 3 o'clock, and of course the great population was working during those hours. So it was an out-of-touch approach. If they'd approached me as a patient voice, I would have on the local radio thing, and I would have talked to Shaw on their presentation. That weekend there was a public gathering for celebrating in Nelson where there was about 1,000 members of families with children and grandparents and all the rest of us, and we stuck a booth up. I could meet people in that town who would have together to try and improve our access to health records. But it was not consulted to us, it was kind of posed upon us. So I think, again, it's the aspect of the patient is not someone who's a token, they are actually a real positive resource. And as we're pushing back, we need the following things, we aren't sure how to do it. You start at all these other aspects, such as, community networks and media presentations and so on, that's outside of the normal responsibilities of someone trying to do research, and they should be expected to learn all of that. We need researchers that are specialized in doing research. The patient voice side of it brings in those other sorts of ways of doing it. And
thank you. Great example.
For us, we started to find more success with recruitment from even just in the last week, recognizing part of it was seasonal in that we started our recruitment in summer and no town in summer, or they have other things going on or that kind of thing. And speaking with our population representative on the team, as well as other people who are part of the research, kind of talked to their friends and said, hey, I'm a part of this, and if you're interested, you can call this number, that kind of thing. So in the last week, we've seen more of that, where I'm speaking with people who are saying, hey, my friend's part of this study, they told me about their experience, so now I'm interested in it. And sort of word of mouth just between people has become more of a thing, too.
It's Karin, if I might jump in from Nelson. I think it's a very good question. Recruitment is a challenge. It's not just in PEiR, it's international, it's across Canada. And I think the benefit of working with a patient partner right from the start can already help tackle that. But the other thing which I often heard, living role and having lived role for about 26 years now, is that many opportunities that are offered in the urban centres, and it can be very frustrating, is the word I heard, and so I will reuse it, where people want to contribute to research, but the opportunity is still offered from an urban lens, and that is from not only UBC Vancouver, for example, as a main university in the Lower Mainland, but as well in the Okanagan, where still that getting together and coming together, which is wonderful if possible. I know the PEiR committee would like to come together face to face, but if we're talking in such a large geographic centre, it is a need, and Paul is putting his finger on it every time, is where the technological infrastructure is an opportunity to help with recruitment. And so it's coming perhaps with the recruitment not only from a clinical lens where people need to be part of blood work or genetic testing, whatever research they're doing, but contributing to the research as well, can be done online and can be done virtual. And there is, as we grow and develop into a learning healthcare system, there is definitely an opportunity, I think, to put more into that. I might be room for one more question, but before we run off and finish this wonderful session, and thank you all very much, I just would like to mention, and Kim has so kindly pulled this up, that the BC Support Unit webpage, it is continuously updated, tons of information, and I must say, and sometimes tiny overwhelming, but you can use the search button on the top, and I found it to be quite friendly so far. But there is an opportunity coming up for grant funding, and the application for submission opened up just last week. Information can be found if you enter the BC Support Unit P2P Awards. Webinar was held on September 14th. It was, I believe, about half an hour, 40 minutes. It's more detail about the criteria for pilot feasibility study. And there, I must say, and this can be, I can share this because it has been noticed that the criteria are quite narrow. However, there is an opportunity for patients and researchers and healthcare providers, clinicians, to collaborate on the design of a research proposal, and the deadline for submission is October 31st. If you have questions, please reach out. There's tons of resources through the IH Research Department to help you develop the proposal if you wish. For the research study, we have people who have hold knowledge on data analysis, who hold knowledge on knowledge translation, who hold knowledge on Indigenous engagement, hold knowledge on patient engagement, ethics, and all sorts of things. So I would really welcome use the opportunity to speak about the resources that we offer through PEiR Health and part of the BC Support Unit. I'm open for one more question.
We do one more question posed to Paul, actually, as you have a minute. The question is that you mentioned patient fora, and can you recommend some that are actively being PEiR that perhaps you're involved with or perhaps you've heard of?
For engagement on things, the Voice Network, you should look onto their website. They post things every month. It gives you a wide spectrum of things. It's how I got involved with it, and I sort of evolved along, and I was doing something useful, and I started watching what they were looking for and found research that was some background and involved with the PEiR programming. I think Voice Network is really the best way. It's very effective, and we to get involved with it.
Great. Well, thank you, everybody, for joining us today. Thank you to Kathy, Karin, Lauren, and Paul for being our presenters. Thank you, everyone, for registering for research and everybody that's able to attend in person. And as we have recorded this session, we'll be posting it online later in the week. Thank you so much. Have a a wonderful day. We look forward to more sessions coming up soon.
Bye.
Thank you. Bye.
Thank you.
Thank